Imagine this. A newborn foal, looks great, totally healthy, gets up, nurses. Everything seems just perfect, right?
Yeah, seems totally normal.
But then, maybe just hours later, that same foal starts to, well, fade. Gets weak, lethargic, gums look pale, eyes turn kind of yellow.
Yes.
What's going on? It's this hidden immunological battle that's just kicked off. Really dangerous stuff.
Absolutely.
Welcome to the Deep Dive. We take the sources you send us, research papers, notes, articles, but like the stack we have today, and we really pull out the key insights. Today, we're diving into neonatal isoerythrolysis, or NI, in foals. It's a critical issue.
It really is. And our mission here is to unpack how this happens, right after a seemingly normal birth. What are the signs to watch for the subtle ones and the really obvious ones?
Yeah.
How vets figure it out quickly, and crucially, what needs to be done for treatment, and maybe even more importantly, for prevention.
So stick with us, and by the end of this deep dive, you'll have a much clearer picture of what is, let's face it, a complex medical problem. You'll get a real sense of that delicate biological balance and why acting fast is so important. It's your shortcut to getting up to speed on something vital.
Definitely. Let's get into it.
Okay, so to really get a handle on this, let's start with the basics. What exactly is neonatal isoerythrolysis? The sources define it as immune-mediated destruction of the foal's red blood cells.
Right. In simple terms, the foal drinks the mare's first milk, the colostrum, which is usually full of good antibodies, right? But in this case, it also contains harmful antibodies from the mare that specifically target and destroy the foal's own red blood cells.
And what's really interesting, or maybe unique, is that this only happens in certain species.
Exactly. It's specific to animals where antibodies don't cross the placenta during pregnancy. Think horses, donkeys, pigs. Their type of placenta is called epitheliochorial. It's like a really effective barrier.
Unlike in humans, where some antibodies get through before birth.
Precisely. So these foals are born basically without maternal antibodies. They absolutely depend on that first milk, the colostrum, to get protection.
Okay, and that dependence is where the problem lies. The foal absorbs these antibodies.
And if they're the wrong kind, the anti-foal RBC kind, they immediately latch onto the foal's red blood cells.
In trigger destruction, hemolysis.
Hemolysis, yeah. Or the body's own cleanup system just removes them way too early. Either way, you end up with anemia, severe anemia. The foal just isn't getting enough oxygen.
And that lack of oxygen, it doesn't just stay in the blood, does it? It causes ripples everywhere.
Oh, absolutely. It's a cascade. You see it in the blood system. Obviously, the anemia, the jaundice from bilirubin buildup, hemoglobin spilling into the blood.
Jaundice, the yellowing.
Right. Then the kidneys take a massive hit. They can get damaged trying to process all the breakdown products, leading to, acute kidney injury. The heart rate shoots up, tachycardia, trying to compensate. And the nervous system, that's really serious. Lack of oxygen or toxic bilirubin levels can cause seizures, poor coordination, even permanent brain damage, something called kernicterus.
It's incredible how one specific immune mismatch can cause such widespread problems.
It really is. Affects the liver, too, potentially. It highlights how interconnected everything is.
So how does this whole unfortunate chain reaction actually start? The sources lay out 3 specific conditions that all have to be met. Condition 1. The foal has to inherit an incompatible blood type.
That's the starting point. The foal gets a red blood cell antigen from the stallion, its father, that the mare, its mother, does not have herself.
And there are specific ones to worry about in horses.
Yeah, the most common culprits are called A and Ka. Those are the antigens usually involved. Think of them as specific flags on the red blood cell.
Okay, and this leads to something really interesting with mules.
Right.
The donkey-horse cross.
It does. Mules are a special case. There's this donkey factor, an antigen all donkeys have, but horses don't. So when you breed a horse mare to a donkey jack,
there's automatically an incompatibility.
Well, a potential incompatibility for sensitization, yes. The risk of the mare becoming sensitized is basically 100%. And because of that, the actual incidence of NI in mule foals is much higher than in horse foals. We're talking maybe 10 to 25% in mules compared to just 1 or 2% in breeds like thoroughbreds.
That's a huge difference. Which brings us neatly to condition number 2. The mare has to be sensitized. She has to have already developed antibodies against that foreign antigen.
Right. She needs to have encountered that stallion's specific red blood cell type before. Most often, this happens during a previous birth.
How?
Tiny amounts of the foal's blood can leak across the placenta into the mare's system, especially during foaling, maybe due to small hemorrhages or if it was a difficult birth,
Okay, so her immune system sees these foreign cells.
and reacts by creating antibodies against them. But here's the key thing, and it explains a lot. This antibody production takes time.
Ah, so the first foal, the one that causes the sensitization.
Is usually perfectly fine. She doesn't have high levels of those specific antibodies in her colostrum yet. It's generally the next foal, especially if it's by the same incompatible stallion, that's at risk.
That makes sense. Are there other ways a mare could get sensitized?
Less common, but yeah. If she ever received a blood transfusion with incompatible blood, that could do it. Or sometimes, though rarely, placental issues earlier in a pregnancy might cause some mixing.
Okay, so incompatible foal, sensitized mare. What's the final piece? Condition 3.
The foal actually has to ingest the colostrum containing those harmful antibodies. And this is why it's so deceptive, because the foal is born healthy, it gets up, it nurses vigorously, doing exactly what it's supposed to do.
But it's drinking in the problem.
Exactly. That first milk is packed with the antibodies, and the foal's gut for about the first 24 to 36 hours is open. It's uniquely permeable to these large antibody molecules.
So they get absorbed straight into the bloodstream.
Yep. After that window, the gut kind of closes, and absorption of big molecules like antibodies drops way off. But in those crucial early hours, those maternal antibodies get in, find the foal's incompatible red blood cells, and start the destruction.
It really is a race against time, against that gut closure.
Absolutely.
So knowing this sequence, what are the warning signs? What do owners or vets need to be watching for? Because again, that healthy at birth thing makes it tricky.
Super tricky. The signs usually start showing up hours to maybe a few days after the foal starts nursing and absorbing those antibodies. Often, it's within that 6 to 72-hour window. Many cases are pretty obvious by 24 to 48 hours.
And how bad it gets varies.
Yeah, depends entirely on how fast and how many red blood cells are being destroyed. Some cases are milder, some are devastatingly quick.
What's the first thing you might notice?
Often just lethargy. The foal becomes dull, weak, loses interest in nursing, might lie down a lot, struggle to get up.
And the color changes.
Big ones. Pale mucous membranes check the gums inside the eyelids. They'll look pale pink or even white instead of healthy pink. That's the anemia.
Okay.
And because they're anemic, their heart rate goes up, tachycardia, breathing rate goes up, tachypnea. They might look like they're working harder to breathe.
And the jaundice, the yellowing.
Classic sign. That's the icterus. You'll see yellow gums, yellow sclera. The whites of the eyes, sometimes even yellowish skin. That's why it's sometimes called jaundiced foal syndrome.
Makes sense. Any other key signs?
Yeah, the urine can change color. It might look reddish or dark brown. That's pigmenturia hemoglobin from broken red cells spilling into the urine. If you took blood, the plasma itself might look reddish too. That's hemoglobinemia.
And in really severe cases, neurological signs. That sounds terrifying.
It is. If the bilirubin gets sky high or the brain is starved of oxygen, you can see seizures, stumbling, inability to stand, really grim signs. Other things might be a mild fever, maybe colic signs, dark tarry manure, and sadly, in very rapid paracute cases, even sudden death.
Any clues from the mare's history?
Definitely. Has she had jaundiced foals before? Or foals confirmed with NI? Especially if it was the same stallion. Or did the mare ever have a blood transfusion? All big red flags.
Okay, so if you see this pattern, normal birth, good nursing, then bam, lethargy, anemia, jaundice. NI is high on the list. How do vets confirm it quickly?
Clinical suspicion is huge, like you said. That pattern is very suggestive. But then you need tests. First stop is usually blood work, a CBC and chemistry panel.
What does that show?
Confirms the anemia, low PCV, often under 20%, low hemoglobin, low red cell count. It shows the high bilirubin, especially the indirect type, which is linked to the red cell breakdown and the brain damage risk, kernicterus, especially if total bilirubin is over 20.
Okay.
You'll likely see the evidence of hemoglobin in the plasma and urine, maybe some other mild changes in white cells or platelets, sometimes low blood sugar, and importantly, you check the foal's IgG levels.
Why is that?
Well, if the foal has FPT, failure of passive transfer, meaning it didn't absorb any cholesterol antibodies, then NI is actually less likely because it didn't absorb the bad ones either.
Right, that makes sense. And then there are specific tests for NI.
Yes, definitive tests. There's a great field test called the jaundice foal agglutination test, or JFA. You mix a drop of the mare's colostrum or serum with the foal's washed red blood cells.
And if they clump up?
If you see clumping agglutination, or even if the mixture turns visibly red from cells bursting, that's incompatibility. highly suggestive of NI.
Okay. What else?
There's the direct antiglobulin test, the D8 or Coombs test. This one actually detects antibodies that are already stuck to the foal's red blood cells, so it confirms that immune-mediated destruction is happening.
That sounds pretty definitive.
It is. And then, of course, you can do blood typing on the mare, stallion, and foal to identify the specific troublemaking antigens like the AA or Kia.
Man, it really is a race against time. So treatment, what are the goals?
Two main goals, and they're urgent. One, restore oxygen carrying capacity. Two, stop any more antibody intake.
And that second one's the first thing you do, right?
Absolutely critical. If you suspect NI within that first 24-36 hours before the gut closes, you must stop the foal from nursing immediately. Put a muzzle on it.
And what about the mare?
You have to milk her out frequently, like every 2 to 4 hours for the next 24 to 48 hours. Get all that antibody-rich colostrum out. Her milk produced after that period is generally safe.
So what does the foal get in the meantime? For immunity and food?
Good question. For immunity, you need to provide safe, banked colostrum known to be negative for those common NI antibodies, AA and Ca. This gives the foal essential general protection.
Okay.
For nutrition, during that first day or two, you use a mare's milk replacer, or maybe milk from a suitable nurse mare. Once that initial period passes, the mare's milk is safe, the foal's gut is closed, it can usually go back to nursing its dam.
What about blood transfusions? When are they needed?
They're often life-saving, but not always needed. It's indicated if the foal's PCV drops really low, say below 12 or 15%, or if it's showing signs of severe oxygen deprivation, like collapse. It's a serious intervention.
And donor selection is obviously crucial.
Beyond crucial, it's key. The ideal donor is a healthy gelding, negative for AA and Co, and importantly, never had a transfusion itself.
Why a gelding?
Fewer potential preformed antibodies compared to mares who've been pregnant. In a real pinch, you can use washed red blood cells from the mare herself. Washing removes the plasma with the antibodies, but that takes time and special equipment.
And the absolute worst donor?
You guessed it earlier, the stallion. He's guaranteed to have the antigen that caused the problem in the first place. Never use the stallion.
Got it. And you always cross-match first?
Always. Always cross-match donor blood with the foal's blood before transfusing. For a standard foal, you might give 2-4 liters of whole blood or 1 to 2 liters of packed cells, slowly over an hour or two.
What other supportive care is needed?
5E fluids are really important. Keep them hydrated, help flush the kidneys, especially with that risk of pigment nephropathy. Sometimes intranasal oxygen is used, but it's not a replacement for blood if they really need it. Anti-seizure meds if they have neurological signs. Often broad-spectrum antibiotics because they're vulnerable to infection. And just good nursing, keep them warm, quiet, minimize stress, conserve oxygen.
Anything to avoid?
Definitely. Be cautious giving plasma for IgG if needed. Make sure it's from a safe source. And critically, avoid drugs that are tough on the kidneys, nephrotoxic drugs like certain antibiotics, immunoglycosides, or NSAIDs, because the kidneys are already under stress.
Okay, looking forward then. What's the prognosis usually like? And how can we prevent this? Prevention sounds way better.
Prevention is absolutely the best strategy. Prognosis.
Yeah.
It really varies. It can be guarded or it can be good to excellent. It all hinges on early recognition, fast diagnosis, and getting the right treatment quickly. With prompt care, survival rates are actually pretty good, often 75 to 90% or higher.
So catching it early, having a good donor lined up if needed, avoiding major complications, those are good signs.
Exactly. On the flip side, delays in treatment, really severe anemia, PCV under 10 or 12, or developing serious complications like kernicterus, kidney failure, liver failure, sepsis, those make the prognosis much worse. And those peracute cases, the really fast ones, they often have a grave outlook.
Which really emphasizes prevention. What are the best ways to prevent NI?
Number 1, if possible, blood cape your mares and stallions before breeding. If you know a mare is negative for AA or Ca and a stallion is positive, just don't breed them together. Avoid the incompatible match. Simplest way.
What if you can't do that or don't know the types?
Then you test the mare late in pregnancy. About 2 or 4 weeks before she's due, take her blood serum and test it against the stallion's red cells, or known AA-Ca positive cells. If her serum reacts, causes clumping or lysis, that's a warning sign. NI is likely if the foal nurses.
Okay, so you know you have a high-risk mare. What's them?
For those high-risk mares or even untyped mares, you can do an immediate cross-match at birth. Collect the foal's blood before it nurses, mix it with the mare's colostrum. If it reacts, that foal cannot nurse that colostrum.
So you need a plan B ready to go.
Absolutely. Muzzle the foal right away. Milk out the mare completely for 24-48 hours. Give the foal safe, alternative colostrum that banked, NI-negative stuff, or maybe IV plasma for passive immunity. Feed it milk replacer. Then, after that risky period, it can usually go back to the mare.
And making sure owners understand the risk for future foals.
Hugely important. Client education is key. A mare that produces one NI foal is highly likely to do it again, especially with the same stallion. Prevention strategies become absolutely essential for her future pregnancies.
Wow. This whole deep dive really shows this hidden, complex immune reaction happening right at the start of life. It turns something essential, that first milk, into a potential threat under specific conditions. It's fascinating biologically.
It really is. And understanding NI isn't just, for vets. It gives everyone a real appreciation for how intricate biology can be and how critical timing and knowledge are for intervention. It's a powerful example of biological precision gone slightly wrong.
Definitely. And it kind of makes you wonder, doesn't it? This specific antibody conflict in foals highlights these unseen biological battles and balances happening all the time. What other simple interactions, things we take for granted, might actually hold this kind of hidden complexity and consequence, maybe even in ourselves?
That's a great question to ponder. There's always more complexity beneath the surface.